I'd like to talk to you today about insights into the regression and progression of coronary atherosclerosis that we've gained from the use of intravascular ultrasound. To begin, it's important to understand that the disease that we're treating, atherosclerosis, remains the most important cause of death in developed countries. Extraordinarily, some 15 years ago, Brown and Goldstein, who won the Nobel Prize for discovering the LDL receptor, actually predicted that heart attacks would be gone with the turn of the century. That was not the turn of the next century. That's the year 2000. The 4S trial had been published and showed that statins could reduce the risk of myocardial infarction, and so Brown and Goldstein said, we got the answer. If we give everybody statins, coronary heart disease will be eliminated from the population. Having won a Nobel Prize, people actually took their editorial in the journal Science fairly seriously. Unfortunately, of course, for all of us, they were completely wrong. In fact, statins have been a major advance in the treatment of coronary disease, but they have not eliminated the disease. If you look at primary prevention studies shown on the left, the 4S trial, about a 1/3 reduction in the incidence of death or myocardial infarction. For primary prevention, the risk reduction is also about 1/3. So that even if we put statins in the water supply, cardiovascular disease would still be the leading cause of death. Now, I think where Brown and Goldstein went wrong is they failed to anticipate the power of the contemporary Western diet, the atherogenic nature of what we eat. And so I've searched the world looking for the world's most atherogenic food. And I went to Asia and I went to Europe and I've gone all over. And I finally found it in Scotland, and I'd like to show it to you. This is the world's most atherogenic food. It's a deep-fried Mars bar. And the way you make a deep-fried Mars bar is you take a candy bar and you batter it and you deep fry it in lard, and it comes out this nice, warm, gooey mess. You eat it, it goes straight to the left main coronary artery, and then you die. And there is no drug that's an antidote for a deep-fried Mars bar. And so the problem hasn't gone away, and therefore it remains one of the most important contemporary challenges in medicine on how do we reduce the burden of atherosclerotic coronary disease. Well, when I was in training some 25 years ago, we thought we understood the disease. We believed that coronary disease was a disease of the vessel lumen. As shown here in the white box, you see stenosis in the vessel. It's magnified on the right side of the slide. And you know, if you had a blockage in the coronary, if you had a narrowing, you had coronary disease. And if you had no narrowing, you didn't have coronary disease. Well, unfortunately, that was an overly simplistic view of the nature of coronary disease. We soon came to learn that, in fact, coronary disease is not a disease of the vascular lumen. It's a disease of the vessel wall. And it is the atheroma shown here in this pathology slide from 3 to 9 o'clock that's the problem. It's the plaque in the wall of the vessel. And the problem with angiography is that it doesn't show us what's in the vessel wall. It only shows us the size of the lumen. And we soon realized that, in fact, the size of the lumen is not a very good predictor of who will actually have a morbid or mortal event from coronary disease. That it was the behavior of the plaque that determined the outcome, not the behavior of the lumen. If that plaque shown here fractures and a thrombus occurs, then patients are going to have unstable angina or an acute myocardial infarction, or worse yet, sudden cardiac death. And so we set out to come up with a method for seeing the plaque in the wall of the artery. And here we were in the mid to late 1980s, and no one had ever seen a coronary plaque in a living patient. And eventually, we settled upon intravascular ultrasound as the modality that we would use for imaging the vessel wall. On the left, you see a schematic of how this device works. It sends and receives ultrasound, as shown here. It rotates 360 degrees, actually at 1,800 revolutions per minute. And in the course of revolving, it sketches out a picture of the vessel wall as shown on the right. And you see the coronary atheroma on the right. That circular object in the center is actually the catheter. The lumen surrounds it. And then you see a plaque extending circumferentially around the blood vessel wall. The dark zone beneath the plaque is actually the vessel media. That's the muscle in the wall of the artery. The distance between any two dots in the image is 1 millimeter. So it's a 1 millimeter scale. So what you're looking at, and what we really were able to see by about 1990, was a very detailed, up close and personal view of coronary atherosclerosis for the first time. And it really allowed us to gain a lot of insight, some of which I'll share with you today. Some insight into the nature of the disease, its development, and how to treat the disease. One of the first lessons we learned remains one of the most important. We learned that coronary disease, by and large, does not actually narrow the lumen. That was a huge surprise when this work was done in the early 1990s. But we now know that when early atherosclerosis begins, as shown in the left panel, the gold area is a small plaque developing in the wall of the artery that then matures over years or even decades. And as the plaque grows, in most patients, it doesn't narrow the lumen. And you can see the lumen is 3.5 millimeters early in the disease, and it's 3.5 millimeters later in the disease. If you were to do an angiogram, at either time point, the lumen would look the same. You would see no narrowing in the coronary artery. And it turns out that something like 97 or 98% of all coronary plaque is extraluminal. It's outside the lumen. You don't see it on the angiogram. It's hidden from view. Without this new technique, we would not be able to understand the pathophysiology of the disorder. It's there, but it remodels in such a way that the lumen is not narrowed. Now, I'd like to illustrate this phenomenon with video. And first, let me show you a still frame of the angiogram. And you see between the gold arrows a segment of the left anterior descending coronary artery, certainly by all accounts the most important coronary blood vessel. You also see that there's no narrowing. Some very sharp-eyed individuals might suggest that there's perhaps just a little bit of luminal irregularity, but it's certainly not diseased, and it was read as normal. Now let's go to the cath lab, and I'm going to show you the angiogram, and then I'm going to show you the intravascular ultrasound, or IVUS. And you can see how the disease is concealed by coronary remodeling. So first we'll play the angiogram and zoom it up on the screen. And you see here a very normal looking blood vessel. And that's the segment of interest with the moving gold arrow. Now I'm going to bring up the video of the ultrasound and immediately see that there's atherosclerosis at virtually every site in the coronary. Look at the size of this crescent-shaped plaque here in the coronary. As you move through the vessel, you see that every millimeter of the blood vessel is just chock full of atherosclerotic plaque. Let me show you now 4 slices of the vessel. Slice number 1, small plaque. Slice number 2, a bigger plaque. Slice number 3, an even larger plaque. And slice number 4, another large plaque. Why do you not see a narrowing in the angiogram? Because the lumen size here and here and here and here is exactly the same. We learned from IVUS that coronary disease is not an intraluminal disease, it's an extraluminal disease. And it was a shocking revelation at the time for a world that was performing several million angiograms every year and believing that what they saw defined the presence or absence of the disease. This phenomenon also explains a lot about the natural history and pathophysiology of the disorder. A number of investigations had shown that the vast majority of lesions associated with an MI, patient would have an angiogram and then have an MI sometime in the next 6 weeks. You go back and you look at the angiogram, and the site that ultimately occluded was about 2/3 of the time was actually not a severe stenosis. It was less than 50%. And only about 1 in 7 MIs, shown here 14%, actually was associated with a lesion that we might call hemodynamically significant. And so all that plaque that we didn't see in the coronary on the angiogram, that was the remodeled plaque, was actually the plaque that was causing most of the morbidity and mortality. This phenomenon also explains other aspects of the natural history of the disorder. If coronary disease were a disease of gradual luminal narrowing, then most patients would present with angina. But instead, the majority of men, 62%, and nearly half of women, 46%, the first symptom of coronary disease is a myocardial infarction or sudden death. They don't have enough luminal narrowing to have angina, but they have enough plaque to cause plaque rupture and sudden cardiac death or an acute MI. Now, I'd like to show you another example of coronary remodeling, one that's designed, in fact, deliberately to be shocking. It's shocking because of who the patient is, the nature of the patient from which these images are obtained. So here you see a coronary angiogram on the left, and I will show you a slice here from the circumflex that's completely normal. A few millimeters proximally, there's a giant plaque, but the plaque is invisible on the angiogram because the lumen size here and here is exactly the same. This plaque was concealed by this positive remodeling phenomenon originally described by a pathologist, Dr. Glogau, sometimes known as the Glogau Hypothesis or the Glogau phenomenon. Now, who's the patient? The patient is a 32-year-old woman who's perfectly healthy until she drives her car into a tree in Cincinnati, Ohio. She has a head injury, and she's declared brain dead. And her family graciously donates her heart for transplantation. Our surgeons fly out and harvest the heart and transplant it into a young man with dilated cardiomyopathy. At the time of transplantation, this young woman, at age 32, had no less than a dozen large atherosclerotic lesions in her coronaries, none of which could be seen on the angiogram, none of which encroached on the lumen. Coronary disease starts out as this extraluminal disease, and only very late in the disease does it actually cause a stenosis. Well, my colleague, Dr. Murat Tushu, was very interested in this phenomenon because it gave us a window on what the coronaries looked like in healthy young Americans, most of whom died in trauma and whose hearts were harvested for transplantation. Let me show you a few of those images. This is a 33-year-old man. On the left, you see his left anterior descending coronary artery with a circumferential plaque. On the right, you see a gigantic plaque in the left circumflex coronary artery. This young man, believed to be perfectly healthy, has a traumatic death. At the time of his death, in his early 30s, he's got atherosclerosis extensively in his coronary arteries. And if that weren't bad enough, here's one more example. This is a 17-year-old young man Man died in of a gunshot wound here in Cleveland. At the time of his death, he has a plaque in his left anterior descending coronary artery that's at least 4 standard deviations too thick to be normal. You probably know this young man. I know a little bit about his demographics. His body mass index was 32. He's that obese teenager you see standing in line at the fast food restaurant getting a supersized fries and burger. By age 17, he's got a very big plaque in his coronary arteries that now, of course, is being transplanted. Now, it turns out that these plaques don't cause a lot of trouble when they're transplanted into a patient, but it tells us a lot about the early genesis of the disease. Dr. Chushu went on and he published his findings, as shown here, summarized in this bar chart. What you see is that amongst, he studied 262 consecutive heart transplant donors, an amazing study. For those under 20, transplant donors less than 20 years of age, 1 in 6, or 17%, already had atherosclerosis in their coronaries. Ages 20 to 29, 1 in 3 patients already had atherosclerosis. Now, I just turned 30, so I would be in this next category, which is a 60% risk of coronary disease amongst 30-year-olds. And at ages 40 to 49 and 50 and above, you can see the incidence was 71 and 85% respectively. Extraordinary prevalence of the disease among transplant donors, suggesting that the genesis of coronary disease, as envisioned by intravascular ultrasound, is very early in life. So, what to do about this problem? We next turned to use this technique to study the disorder in a randomized clinical trial. And this is the flow diagram for the trial. 654 patients at 34 centers with moderate coronary disease, studied with an ultrasound device, 30 megahertz, and randomly assigned. Half of them got moderate lipid lowering with 40 milligrams of pravastatin, and half of them got very intensive lipid lowering with 80 milligrams of atorvastatin. We completed 502 out of those 654 patients and obtained a second IVUS. And the question was, would we see progression, stabilization, or regression of disease? Well, these images are analyzed in a core laboratory where, as shown here, technicians trace the lumen area, they trace the external elastic membrane area, and they calculate the area shown in gold, the atheroma area. That process is then repeated, as shown in this slide, at a series of slices exactly 1 millimeter apart. And so in this example, there are 48 cross sections being measured. I will show you the 10th, the 26th, and the 48th. You can see here that they're very atherosclerotic. There is plaque everywhere, even though the angiogram is not terribly abnormal. Let me now show you a video that shows a typical motorized pullback where the catheter is being pulled back through the artery, and you will see a running total of the amount of plaque in the coronary slice by slice. So here you see there's 50 cubic millimeters, there's 100, there's 150, 200, 250, 300, 350, and now 400 cubic millimeters of plaque. This right coronary artery in a single pullback has more than 400 cubic millimeters of plaque. Extraordinary disease burden. What will happen to that plaque? Will it get bigger, get smaller, or stay the same? So, in the reversal trial, studying moderate versus intensive lipid lowering, the moderate group reached an LDL of 110 milligrams per deciliter and the intensive group got lower to 79 milligrams per deciliter. In both cases, the patients were treated, but in one case more intensively. What was the net effect? Well, it turns out that in the group that got moderate lipid lowering to an LDL of 110, there was unequivocal, statistically significant progression of disease, shown here in blue. In the group that received more intensive therapy, there was actually less plaque at the end of the 18 months than at the beginning of the study, although statistically it wasn't below zero. So in other words, we can say, based upon these findings, that lowering LDL to approximately 110 is associated with unequivocal progression. Lowering LDL to 79 was associated with no progression, although there was also no regression. Let me now pause, and we will resume in a minute.